morning, everyone. I want to thank David and Heidi for inviting me to talk here. It's a real privilege. I especially like the opportunity to speak to such a broad array of clinical providers, ranging from the very frontline staff to people who help set the national and international agenda in HIV care. So it's a particularly valued opportunity for me for that. People who know me well know that Moby Dick is my favorite novel, and so that either means I'm really, really smart or really, really weird. But it is my favorite novel, and so with apologies to Herman Melville, I've decided to entitle this talk Retention in HIV Care, or The Gorilla. So just a brief review of what I hope to achieve today. So I want to review the importance of retention in HIV care, help for you to learn some approaches to measuring retention in HIV care that are actually appropriate for routine HIV care. Learn approaches to improving retention in care, and then review very briefly some studies that are underway to keep your eye open for. As a good Hopkins trainee, I'm going to start with cases. So Mr. W, 28-year-old black male, diagnosed with HIV late 1998. He was hospitalized at our county hospital, which is called Ben Taub. At the time, he had very, very advanced CNS toxoplasmosis, wasting. He weighed about 120 pounds, dementia to the point where he was unable to make medical decisions for himself, CMV esophagitis, and a CD4 count of 6. Mr. T, about the same age, 26-year-old black man, diagnosed also at the same hospital, around the same time, 1999, he was diagnosed because he presented with pulmonary tuberculosis and had a CD4 count of 265. So the simple question is, which patient is still alive today? Now, this actually is not an audience response question, so you can put your little keypads down. Those of you who want to play the odds, it should be that the person with the high CD4 count is alive today and the person with the most advanced disease died. Those of you who are good test takers know that the counterintuitive answer is often the correct answer on the test, and in fact, Mr. W is the one I saw a month ago, and he's doing fine. So Mr. W survived his initial hospitalization, showed up at Thomas Street with his mother, and that's a very good prognostic sign, in my unscientific opinion. And had to be discharged to his mom's house because of his dementia. But he showed up with his mother, was prescribed antiretrovirals, started therapy, took his medicine, and maintained really excellent appointment adherence and stayed in care. As I said, I saw him last month. His CD4 count is in the 400 to 500 range consistently. He's up to 200, and he actually needs to lose a little weight, 200-something pounds. He's got diabetes and a buffalo hump, but otherwise he's doing great. He's got a job. He's a very productive member of society. His dementia cleared with treatment of his HIV and toxo. The other patient, Mr. T, died about 5 years ago. He never could quite get fully engaged in care. He was diagnosed with TB. He got DOT. He completed that successfully. He got on ART, and then he felt better, and he disappeared. And then he'd get sick again, and he'd show up in clinic again and get treated for a little while, and then disappear again when he felt better. And this went on for years, and about 5 or 6 years ago, his CD4 count had never really improved. He ended up with M. kansasii, pulmonary infection, and there's no DOT for non-tuberculous mycobacterial infections in Houston, and he never took his medicines for that either, and eventually he went to hospice and died. So, very briefly, I want to talk about the prevalence and impact of poor retention in care beyond these two cases. So this is an audience response question. What proportion of your return patients to your clinic fail to attend their scheduled visit? What proportion of your patients no-show for a visit? Is it 0 to 10%, 11 to 20%, 21 to 30? We have an answer. That was quick. Okay, I didn't know if I didn't know if that was going to show up with and show the answers immediately or not. So I don't know if everyone had a chance to reply. If you didn't, I apologize. Can I re-poll? How do I do that? If I go back, will it do it?
There's a reset.
Well, we'll just have to skip this one. Just looking at the brief responses, it looks like there's a fair amount of no-show. The highest response, which may have been 1 out of 3, was 21 to 30%. So that's consistent with a lot of other data. So this is in my opinion, all too famous HIV treatment cascade. It is a concept that's been around for a while and recently very popularized. But these are the CDC's data on the proportion of people at various stages of the HIV treatment cascade. And so the basic idea is, as I'm sure most of you know, there's about 1.1 million, 1.2 million people living with HIV in the US, and of those, only about 80% are diagnosed, and the rest are undiagnosed. So there's 950,000 who are diagnosed. And of those, only a certain proportion have been linked to care, so you end up with 725,000 linked to care. About 480,000 are actually retained in care. 427,000 are on treatment, and 328,000 are actually suppressed. And this is a snapshot of where the nation was according to best available data in using data from 2009, 2010-ish. The way most people talk about the cascade then is they look at this and they say, wow, only 28% of the people with HIV in the US have viral suppression. And that's probably fairly close to the truth. And 72% of people with HIV in the US are non-suppressed. And that's a real call to action, that most of the people, the vast majority of people with HIV in the US are not suppressed. There's a different way to look at the cascade, though, and I credit Reve Amico for giving me the idea to look at it this way. What if you only look at the people who are non-suppressed? Because when you look at the cascade slide, it's just sort of a gradual trickling down. But let's look at just the 850,000 people who are not suppressed and see where the opportunities for improvement are. If you look at the people who are not suppressed, you can see that a lot of them, 28%, are not suppressed because they're not diagnosed. 25% are not suppressed because they're not linked. 29% are not suppressed because they're not retained in care. Once they're in care, only 6% are not suppressed because they're not on ART, and only 12% are not suppressed because they're on ART but don't have viral suppression. So if you were going to try to improve the number who were virally suppressed in the US, these diagnosis, linkage, and retention are your targets. Apologies to the pharmaceutical company people here, but we don't need, and maybe I shouldn't even say that. We need better ways to get drugs in people's hands. I won't say the other part of that comment, because we do need new drugs. But that, if you really want to improve the public health, the answer is here. The individuals, there certainly is a need for more drugs. Now, so a lot of people are not retained in care. And if you look to, okay, that's the magnitude of the problem, what about its impact on outcomes? And there's a wide body of literature that shows the impact on outcomes. And this is data we published a number of years ago now that looked at survival based on retention and care status. This is from the VA. It's a nationwide VA database that we used. And we simply looked at people who were starting ART, who lived at least 1 year after start of ART, and we used that 1 year as their observation period to assign them as some level of retained in care. We divided the year into 4 3-month quarters, and we said, okay, did they have at least one visit with a physician who could provide HIV care in the VA in each of those quarters of the first year? And then we looked at survival after that first year, and you can see that we've got 5, 6 years of follow-up here. The dashed line that emerges on top is the people who had 4 out of 4 quarters with a visit. The solid line that falls to the bottom is the people who had only 1 of 4 quarters with a visit, and that one visit was actually when they entered the cohort. And you can see that the other 2 groups are in between. So retention and care predicts survival in unadjusted analyses. And then when we adjusted for CD4 count, antiretroviral use, Hep C status, age, race, etc., you could see that the people with the worst retention and care had nearly 2 times the mortality hazard as people who had the best retention and care. This observation has been corroborated in a number of different data sets, including a study by Mike Mugavero and colleagues at UAB with the 1917 clinic, where he looked at a different way of measuring retention and care, just a simple metric of missing 1 visit in the first year after they established care. Now, his cohort's a little different because his patients didn't have to be starting ART. He just looked at everyone who showed up for their first visit at the 1917 clinic, and he found, in fact, that if they just missed 1 visit in that first year, their hazard of death was almost 3 times those who had no missed visits. So retention and care clearly is of critical importance if you want to improve survival with HIV. So that's all I'm going to say about why it's important. That could be another talk in itself, but I don't think that's really the point of today. The point of today is to get into what we can do to improve retention and care. So retention and care is the gorilla. Now, how do we measure retention and care? If you're going to address retention and care, you got to know a little bit about how to measure it. This could be a talk unto itself. I could go on for at least half an hour on this one slide. I'm not going to do that. I will refer the interested audience member to a Medscape article that I wrote on how to measure retention and care, and there's a few other papers that are out there on that. I just want to make a couple comments on this slide. The first is, this is not an exhaustive list of ways to measure retention and care, but it does list the more common measures. And it goes over some of the ease of calculating the measure, the follow-up time that you need. Obviously, you're talking about retention and care, so you need a little bit of follow-up time. It's not something you can do with just a quick, with someone who's only been in your clinic once. There's some things you have to think about as potentials for misinterpretation. You can read this on your own because the slides will be available if they're not already on the website. But I do want to make a couple quick comments. First of all, if you're thinking about measuring retention and care, you need to know up front, does your measure or does your system that you're going to use have data on missed visits? Because if some systems keep the data on missed visits, and some systems only retain data on attended visits because they're basically for billing purposes. So if your appointment system or your data system that you're going to look at retention doesn't have data on missed visits, then you can't do this first set of measures. Now, the first set of measures that uses missed visits are basically, we call them adherence measures because you're trying to say this person is adherent to their visits or not. And one of the more common ways to do it is to calculate a percentage of visits attended. The way Mike did it in his paper that I just presented was, did they have any missed visits, or you count missed visits. Another way is to say, did they attend the visits that they were supposed to? And you just take all their visits that were scheduled as the denominator, and the numerator is the number they attended. Pretty simple. You can also look at no-show rates, which are nice from the clinic's perspective, a little maybe less meaningful from the patient's perspective. And these measures, as I said, are called adherence measures of retention in care. Now, you have to be careful with them. There's a potential for misinterpretation because a person who has no visits scheduled is going to have no missed visits, right? But that's clearly not being retained in care if they have no scheduled visits. On the other hand, if they've only got 1 scheduled visit and they attend it and never schedule a follow-up, they have 100% of appointments attended. That's clearly not retention in care if a year has passed. So you have to be careful about these measures. There is a potential for misinterpretation. The flip side, again, is if you've got automatic rescheduling in your clinic, that people who miss a visit end up getting automatically rescheduled, and they may not even know about that new appointment. You can have 2 or 3 missed visits despite the person not even knowing that they had those visits scheduled. So be careful about that. The other sort of measures for retention and care is called constancy measures or persistence measures. You'll see both terms. They do not require missed visit data, and they look at whether a certain number of, a minimum number of visits over some sort of time period were attended. So did the person, as I showed you in the VA study we did, we said, did they have at least one visit in every 3-month block of the first year of their HIV treatment? Doesn't matter how many visits they had scheduled, how many visits they missed, they needed to just attend at least one visit per quarter. And you can do that per 3-month interval or per 4-month interval. You can do something about per 6-month interval. Wayne Duffus did that with South Carolina data. The HRSA-HAB measure that a lot of you are reporting, if you're Ryan White funded, is a variation of this where you've got 2 visits over the course of a year with at least 90 days in between. And so those are nice because it doesn't matter how many visits they missed. The downside of those is that there's no sense that, there's no accounting for the patient's disease severity. So if the person is really sick, 2 visits over the course of a year with at least 90 days in between them is not enough. We know that clinically, but the measure doesn't account for that. On the other hand, if someone is doing very well, that may be perfectly adequate. So they're kind of a least common denominator approach. And then there's gaps in care, which is very intuitive. Did the person go at least a certain number of days without a visit? 180 days is typically used. And that's nice. And the nice thing about that is you're looking at a person's chart. They're on your schedule. You can see, man, it's been 9 months since they were here. That person's not retained in care. Easy to do immediately. Difficult to do from a research standpoint sometimes. It gets a little tricky. And again, if you're interested in the ways to measure or more on this topic, there are a couple articles out there in the literature that I'd refer you to. So that's all I want to say about how to measure retention in care. So does anyone know what this is? What? A couple of white guys. They're very well-known white guys, Dr. Smith. Here, maybe this will help. Doubting Thomas, thank you. Was that David or Joe? Dr. Aaron gets the nickel. Yes, so this is how we as healthcare professionals learn. We're empiricists. We want to know the data, right? This is Thomas the Apostle, who said after he heard that Jesus had risen from the dead, he said, I don't believe it. I'll believe it when I see him, when I can put my fingers in his wound. And this is Verrocchio's statue of that event when Thomas sees Jesus and you can see the wound in his side and Thomas is about to touch the wound. This is how we are taught as healthcare professionals to know something. So to us, retention in care is a no-brainer. Why don't people stay in care? If untreated, HIV is a fatal disease. Good treatments are available. You get those good treatments by going to the doctor or going to your nurse practitioner or PA. What's the problem? Why would you not avail yourself of those treatments? You're going to die otherwise. It doesn't make sense to a lot of us that people don't stay in care. Okay, so this is an audience response question. I will give you time to answer. If you heat water past a certain point, you see a substance rising from the water. That substance is A, smoke from the water burning, B, water in the gaseous phase. Now, the good test takers in you are thinking, he already tricked us up once. Which one is it, A or B? There's no C. The problem is that my eyes are bad. I can't see the responses are pouring in. Come on, guys, this isn't a trick question. The answer is, 5% thought I was trying to trick them. The correct answer is, if you heat water, you get steam, so it's water in the gaseous phase, right? Okay, next question. Keep your thinking caps on. If you heat wood past a certain point, you see a substance rising from the wood. That substance is smoke from the wood burning or wood in the gaseous phase. Please answer. And the answer is 7% still thought I was trying to trick them. It's smoke. Now, how do at least 93% of us know that it's smoke and not wood in the gaseous phase? we've learned this over time. When you cook, you see the steam rise, you put a lid on the pot, you take the lid off, you see water dripping out. You know that water, if you heat it, gets to be steam. You know from sitting around campfires that, that wood, when it burns, releases this stuff that irritates your eyes. You can, as it cools down, it doesn't turn into little particles of wood floating down. We've all taken chemistry. We've boiled water before. We know that water has a boiling point. You don't talk about wood's boiling point. So you know this in the back of your mind. You learned it over the year. You've seen it. You've experienced it. And you know. Now, why don't people stay in HIV care? We know that wood turns to smoke when you heat it, that water turns to steam when you heat it. But our patients don't necessarily know what we know about HIV care. They don't know it the way we do. They haven't seen people necessarily, they haven't seen people die of HIV. They haven't seen the Lazarus effect of the HIV medicines, people rising from the dead practically. People who, and when you look at the research, the things that predict or make it more difficult for people to stay in care make sense if you think about it this way. People who have lower perceived need for care, they feel well, have trouble staying in care. People with fewer non-HIV related comorbidities have trouble staying in HIV care. People who use substances and have mental health problems, they have trouble staying in HIV care. To them, it's not a simple equation of HIV care is good for me, therefore I should do it. There's other things getting in the way. People who don't think that they can benefit from the care are going to have trouble staying in care because they don't trust us, because they haven't, they've seen people die from taking AZT in their mind. That's how they put it together. People without the kind of social support that is required to successfully deal with this highly stigmatized disease. And stigma by itself will keep people out. We have patients who don't want to come to our clinic because it's known as an HIV clinic. And I'm sure everyone has stories like that from their clinics. People are afraid to come, and short-term fears can trump long-term perceptions of benefit. And then there's denial. They don't want to come because they don't want to admit to themselves that they've got HIV. And then there's a lot of literacy issues, people just not knowing where to go. And this gets into system factors too. Unmet needs. If you don't know where to go, you don't know how to get there, you don't know how you're going to keep a roof over your head, these are barriers that can overwhelm any kind of simple equation of there is treatment available and therefore I should avail myself of it. There's very confusing healthcare systems out there, especially, ironically, the sicker you get, the more difficult it is to navigate the healthcare system because the more access you need to get into different systems to access ADAP medications, to access home-based care, to access durable medical equipment. Those systems are very, very confusing. There's multiple layers, and it gets difficult to navigate that. People without insurance obviously have to go through different routes. And then there's just simple cost issues. The opportunity cost of attending a visit, the physical co-pays that can keep people out of care, or at least make it difficult to stay in care. So people don't stay in care because it's not that simple to them, although it's clearly a simple equation for us. Now, one way to think about these factors is the information, motivation, and behavioral skills model. So Jeff Fisher, Reve Amico developed the information, motivational, behavioral skills model around condom use in HIV prevention. And then Reve modified it to talk more about adherence to antiretroviral therapy. And then Laramie Smith, who's a fellow working with Reve, and Reve modified it to talk about retention in HIV care and called it the situated IMB model. Now, it's a very busy slide. I'm not going to go over it in detail. But the basic concept is this. If you are trying to understand whether people will stay in care or not, or attend a specific visit, scheduled visit, one way to think about it is that the patient needs to have the information necessary to decide to attend. So they need to know about the visit. They need to know that it's important. They need to have some motivation to help them go through the hoops that you have to do, miss time from work, miss time from home, whatever, to have the motivation to value that enough that they'll actually do it. And then they need to have the behavioral skills to execute. They need to know how to schedule a visit. They need to know how to access transportation. They need to know how to find a babysitter if need be, and so on. They need to be able to get those things done so they can literally make it there. And all this also has to happen within a context of that patient. The context might be substance use, mental health problems. The context might be a very confusing healthcare system. It might be a very streamlined healthcare system. It might be a city with terrible public transportation like Houston, where you got to take 3 buses to get to our clinic. Or it might be a city where it's pretty easy to get around like Boston or New York, where you can access a pretty good public transportation system. So all that context matters. And then the clinic factors are also in the context. You know, what's the wait time like? So think about, you know, the basic idea is you need information, you need motivation, and you need behavioral skills to get to a desired behavior. So with that in mind, I'm going to review now the data, randomized clinical trial data on retention in HIV care. So what's out there as the evidence base? This is the first study that was a randomized study that focused on, actually in this case, linkage to care. It was the ARTIST study done by Lit Gardner and colleagues in 4 cities with 273 participants. People were randomized, people who were newly diagnosed. 78% were diagnosed within 6 months. The others were diagnosed longer than that, but hadn't accessed care. They were randomized to either 90 days of a strength-based case management or usual care. Strength-based case management is probably well known to the social workers and case managers in the audience. For those of us who are not that, it's basically figuring out what people's strengths are and then building around that to help them link to HIV care. It was a 90-day intervention. So one example would be, wow, you're homeless, you're living on the streets. Well, that actually takes a lot of skill to survive on the streets. And then you work through with the patient to figure out what the skills are that allow them to survive on the streets and help them use those same skills to get into HIV care. So it worked. If you look at 6-month attendance in HIV clinics, 78% in the intervention arm versus 60% in the control arm linked to care. And then when they extended that out to 12 months and required an additional visit in the second 6 months of the year, the intervention arm still had a statistically significant improvement over the control arm. This study was replicated in ARTIST-2, which is usual care sites, community care sites, and is now available for dissemination at CDC. They'll happily train people in the methods of ARTIST-2, and a lot of jurisdictions have adopted these methods for their linkage to care efforts. The next study is not yet published. It was presented at the Miami Adherence Conference, and it was led by Lit Gardner as well. And it's a 6-site study. You can see the 6 sites here. And it was a randomized controlled clinical trial. This is the retention and care study. So what we did was enroll about 300 people from each clinic, so a big study, and randomize them to one of 3 arms. The third arm was usual care. And these were people who were out of care initially, not necessarily newly diagnosed, but out of care. And then they got randomized, so the usual care arm or 2 intervention arms. And the 2 intervention arms were very similar. So the enhanced contact arm got a session 1, which was some introduction and some HIV education about importance of HIV care. They got reminder calls 7 and 2 days before their primary care appointment. They got a phone call if they missed an appointment to try to re-engage them. They got a brief face-to-face visit with the retention specialist, the interventionist, at every attended primary care visit just to say hi and update their contact information. And that was in both arms, and that's the enhanced contact arm. The enhanced contact plus arm also got, and this is the only difference between the 2, they got screened for missing skills, and then were delivered a brief intervention around any skills that they were deemed to be in need of some training on. And the 3 skills they could have gotten training on were how to talk to your doctor, how to problem solve, and how to organize your life, you know, calendaring and that sort of thing. And so they went through a brief screener, and then they got those skills addressed in very brief sessions, 20 minutes, 30 minutes. That was the difference between that's the plus in the EC plus arm. The intervention lasted a year, And the preliminary results, as I said, were presented last year in Miami, and that paper is under review right now. And so that preliminary analysis looks at that same intervention year to see what the retention in care was. And here are the results as they were presented. You can see pretty quickly that the enhanced contact arm had about 10% higher retention in care using a 4-month constancy measure. So you divide that year into 4-month blocks, 3 4-month blocks. So they have a visit in at least every one of those 4-month blocks. 55% in the intervention arm did, 55% in the enhanced contact plus arm did, and you can see the control arm obviously is the same. So the enhanced contact helped. But the two intervention arms were no different from each other. When we looked at adherence measured by proportion of kept visits attended, so adherence percent, you can see again that 72%, 70% in the intervention arms attended visits, or 72% of visits were attended, and that was higher than in the control arm, so about a 5% higher increase in appointment attendance. Again, no difference between the two arms. So the intervention was successful, and it suggests that these extended enhanced contact, appointment reminders, some face-to-face, a little bit of education can increase retention in care. And that is the end of the randomized clinical trials data for retention and care interventions. There are no other published studies. That's clearly, well, in my opinion, that's not enough to act on, but we still need to act. We need to improve retention and care. We can't sit around and wait for more randomized data to come out. So what do we do? Well, the IAPAC convened an expert panel to address retention and care as well as linkage to care and adherence to medications. And these are their summaries about what we could do after a very thorough literature review on retention and care. And now you guys know where the evidence that they cited is. So the first thing they said is you got to measure it. Systematic monitoring of successful entry into care is recommended, and systematic monitoring of retention in care is recommended. So that's easy. You can't fix something unless you measure it. Then they said brief strength-based case management for individuals with a new diagnosis is recommended. That's the ARTIS study results. And those are both fairly high-level recommendations, 2A and 2B. And that's it for the strong recommendations. Now, the retention and care study randomized trial has not been published yet, so they didn't have that to go over. But they also, so all they could do now is go on observational data. And their summary of the observational data was that intense outreach for individuals not engaged in medical care should be considered, and that peer and paraprofessional patient navigators should be considered. So that's the evidence-based summary. Okay, another audience response question. In what proportion of patient encounters do you discuss adherence to antiretroviral medications? All right, let's see where we are here. Almost every visit. That's fantastic. That's exactly what's recommended. 75% of you discuss it in every visit or nearly every visit, and that's where you should be. In what proportion of patient encounters do you discuss the importance of adherence to clinic visits, not HIV medications? So still almost half discuss it in nearly every visit. That's great. But there's a wider spread here. Would that help? I don't know. I will go over some data in a minute that might give you some answer to that question. One of the things we have to do, though, is figure out how to talk to patients about the importance of attending visits. So let's go over this question. Oh, you can't really read it. Imagine I'm your dentist, and imagine you're a little overdue for your dental cleaning, your teeth cleaning. It's been a year. You know you're supposed to get your teeth cleaned every 6 months, right? I tell you, as your dentist, you know you really need to get your teeth cleaned every 6 months. Bad things could happen to your teeth if you don't. They might even fall out. This statement makes you feel A, more knowledgeable, B, guilty and imperfect, C, more motivated, D, mad like you're being treated like a child. Choose one, only one. So, only 3% were informed by my statement. Only 19% were more motivated by my statement. And the rest of you, almost 80%, this statement had a backfired. It did not work. Huh. Some of the clinicians, the MDs in the audience might be thinking, Well, Ira Wilson tested this exact approach. Not at retention and care, but on adherence to antiretroviral medications. Ira is a great researcher now at Brown. Clinicians have been saying for years, God, if I only knew if my patients took their medicines or not, I could really help them. But I just don't know because they all lie. When I ask them, they say, oh yeah, I take them all the time, right? So Ira said, enough of this. Let's figure this out. So he designed a study where he would give providers real information about their patients' adherence and see if that would improve patients' adherence. So he enrolled about 120 people. He randomized them. And everyone got their adherence assessed by MEMS caps, which are those electronic pill caps that they record every time the bottle's opened, and then the data get dumped to a computer. So you really know when the pill bottles were opened, and they're told not to use pill boxes and so on. They also gave a self-report of their adherence to medications. They self-reported whether they used reminders, why they missed doses, their beliefs about ART, their alcohol and substance use, depression. They filled all this out at every visit. And half the times, and the people in the intervention arm, the clinicians got that data real time. They knew if their patients were taking their medicines because they got the MEMS data. The other half, the visits, the providers did not get that information. It was gathered but not fed back in real time to the provider. And then I recorded the patient-provider interview, the patient-provider visit, and then analyzed the data, listened to all the audio recordings, and categorized all the speech into categories of, social stuff, instructions like, oh, let's, come back in 3 months, and adherence talk. And you can see, and then they just counted the number of utterances in each category. So, and then they went ahead and looked at adherence after this intervention. So what they found is that adherence dialogue increased. So this is just counting the median number of utterances in the visit. There are, the talk about physical health, 120 versus 97, not statistically different. Talk about antiretrovirals, almost went up statistically significant level, 76 versus 50. Adherence of the current regimen, the talk was statistically more in the intervention arm, 51 utterances versus 32. The median utterances on ART problem solving, however, was still 0 in the intervention arm. It was more common because there were more people in the tail end who did talk about adherence problem solving, but the median was still 0 utterances on problem solving. And then when you look at, so there was very little problem solving dialogue, despite knowing what your patient's adherence was. And when he looked at subsequent adherence, it was no different. So simply saying, you need to take your medicines, you need to attend your visits, as you guys just confirmed, is not a productive strategy. And Ira has objective data and adherence to show that. We need to problem solve. Now, where do we need to problem solve? The SPINS projects looked at adherence to retention and care and identified a very key concept, and that is that you don't need to wait for people to be out of care to focus on keeping them in care. That people are cycling through, they're in and out of care all the time, and that you need to work both on finding people out of care as well as working with people who are currently in care, because everyone is at some risk of falling out of care. So interventions can actually target people who are currently in the clinic. And this was a study we did. It's not randomized, but it was the same CDC group that did the study that I presented the randomized data. We did this while we were waiting for the randomized study to take off. And we did a clinic-wide intervention about retention and care. What could we do at the clinic level? This was published already. So we just devised basically a social marketing approach. And we said, let's come up with a theme. Okay, how about stay connected for your health? Let's train providers about the importance, to speak to patients about the importance of regular care and keeping appointments. And basically, these are very, very brief provider-delivered messages. It's really important for you to come into your care. Together as a team, we can make a difference. I'm really glad to see you today. It means that you're here to help take care of your HIV infection. That's great. This is the way we can deliver your best possible care by staying in care. Stay ahead of the virus, attend your visits. Very brief messages. And this was clinic-wide, so the frontline check-in staff also got trained on this. And their message might have been as simple as, great to see you today. Everyone got a brochure at every visit, and it's provides some information, some motivation, and some skills about how to stay in care. There were waiting room posters and exam room posters. And it worked. It wasn't a huge effect, but it did work. You can see that overall, without adjustment, in the intervention year, what we looked at to measure whether it worked in this case was starting from a time when you attended a visit to receive the intervention, did you attend the next 2 visits afterwards? And and then we compared that to a pre-intervention year. And you can see in the intervention year, 58% of patients met the retention measure versus 53% in the pre-intervention year. So a 5% absolute improvement, a 10% relative improvement. And after adjustment, that remains statistically significant. And you can also see that it was improved in all sub-categories. And I didn't know how this would project, so I made a blow-up version of that. But you can also see when we looked at appointment attendance as a percent, about 70% of visits were attended in the pre-intervention year and 72% in the intervention year. Small, but statistically significant improvements. And as a clinic director, if you told me I could improve attendance by a couple, 3%, that's actually not trivial, especially when it's such a low-effort intervention. And we have actually a cost-effectiveness analysis underway. It also is important to note that it worked in people who were new or old patients, and it worked even more so in people who had detectable viral loads, so an important target. Now, the SPINS outreach intervention looked at predictors of retention and care over time. And what they found was that baseline engagement predicted outcomes, but not completely. So there was this cycling where people did fall in and out of care. And factors associated with retention at 12 months were discontinuing drug use, decreased structural barriers, decreased unmet needs, and stable beliefs about HIV. So this gets to the point in the guidelines about how important it is to try to decrease unmet needs and increase social support, get people to address substance use problems. And one thing that we're really interested in and working on now, which is, I give credit to a fellow of mine, Bic Dang, is patient satisfaction as a novel way to improve retention in HIV care. So we did a cross-sectional study in Houston, and we measured patient satisfaction, we measured viral suppression, we measured adherence to antiretroviral therapy and retention in care. And when we looked at the data, as you would expect, retention in care predicted viral suppression, adherence to medications predicted viral suppression, and patient satisfaction predicted viral suppression. Then we put everything into a structural equation model. And in fact, patient satisfaction, feelings about your care and likelihood of recommending your care to others, predicted retention in HIV care and adherence to antiretroviral therapy, which in turn predicted suppression. But all those predictions were statistically significant. Now, this was cross-sectional data, so really you have to say associated, not predicted. But it raises the very intriguing possibility that if you could just improve your patient satisfaction without necessarily improving the quality of the care, have a more friendly staff, have a smoother appointment in terms of the logistics of it, less waiting time, you might actually improve adherence to medications and retention in care, because a more satisfied customer is maybe more likely to stay in care with you. And that's something that the airlines and Gap and Microsoft and Apple figured out decades ago, right? So what other research is ongoing right now? Well, as I mentioned, there's our study results are in review for the CDC Retention and Care randomized trial. We actually have an additional year of follow-up to see if there was any post-intervention effect. Billy Cunningham in Los Angeles has a peer intervention he's working on in jail releasees. That's a randomized. These are all randomized trials. Rafael Sauter in New York City has a navigator by contingency management intervention in substance users. Contingency management is, people show up for their visit, you give them a reward, money or a lottery ticket or something like that. And so she's got a randomized trial going on in that substance using MSM population. I have a peer navigator intervention going on in people hospitalized with HIV who are out of care in our public hospital. The HPTN study is a huge study that's studying contingency management for people who are newly diagnosed and seeing if that will help them link to care, as well as achieve viral suppression and retention. Lisa Metch, who was in Miami, is now in New York, and Carlos Del Rio in Atlanta have a HOPE protocol funded mainly by NIDA that uses contingency management in hospitalized substance users. Lisa's also got a trial going on in in crack users about co-located substance use treatment and navigation. And then Mike Magavero has a randomized trial in using our CDC intervention as well as the PACT intervention, which is an evidence-based intervention to improve adherence to HIV care. So there's a lot in the pipeline. But I think we're still looking at, aside from the CDC study, a couple years for most of these, if not more. We have to act on what we've got, and so let's talk a little bit about what some people are doing, some really innovative program interventions. There are some really neat public health interventions where people are using the public health approach. They're using the data that are required to be transmitted to public health authority and using that to try to improve retention in HIV care. So Washington, D.C. did a retention blitz where they got the citywide data on retention and care and fed it back to clinics and said, you know what, it looks like these people are out of care, you should try to reach out to them and get them back in care. And it actually had some effect. LaFi is a well-known program in Louisiana where they actually built a data system, statewide data system, and people entering the LSU healthcare system at the emergency room, doing anything in the LSU system, if they were HIV infected and out of care, a pop-up would show up in the EMR saying, this person, based on our data sets, looks like they're HIV infected and out of care. What do you want to do? And there was a checklist that they could do. King County, Seattle, has an approach where they are using the public data, publicly reported data, and going out. The King County Public Health Authority itself is going out to find the people who are out of care, not relying on the clinical sites, or not waiting for people to hit the ER. And in my discussions last night with some of the attendees, it sounds like North Carolina is actually moving in that direction. So that's a very aggressive and potentially very important way to address this problem. There are other care delivery models you can consider. The medical home concept, which a lot of people are moving towards, actually is perfectly suited towards retention and care activities, right? Because you're supposed to build databases, you're supposed to try to keep your people engaged in care, you're supposed to deliver comprehensive care, defragment care, and so whether that will have an impact is unknown, but it makes perfect sense that it would. Open access has been widely touted as a way to improve efficiency in the healthcare system. I don't know of any studies that have looked at whether that improves retention in HIV care, but it's not hard to imagine that it might. Telehealth, we were discussing this last night a little bit, especially in areas like North Carolina, where there's a contingent of people with HIV out far from the medical centers of excellence who need access to specialists. Could telehealth be used to improve access and retention in HIV care? And then there's an issue with consultancy in primary care. You know, could you improve retention in care by actually becoming more of an HIV consultant rather than trying to deliver all their care and making them come to the expert all the time? The expert is the expert in HIV care, not necessarily the expert in primary care. I don't know if that would work, but it is something to consider depending on the local context. And finally, there was the In-Care campaign over the last couple of years that the National Quality Center in New York ran, which was basically a quality improvement program nationally to get people to focus on retention care. And I'm sure many of the people here participated in that. So let me take the last 2 minutes to just go through some quick recommendations. We've seen the data. Evidence base is not that developed. There is a fair amount of observational data. We need to act now. So what could we do? The first thing is if you're not measuring it, you can't fix it. So you have to track your no-show rates and figure out who's out of care, figure out who's in care in your clinical setting. That is clear. You need to try to minimize unmet need. Strengthen access to substance use, mental health, case management services, social services. Those things are well-known barriers to keeping people out of care, and it makes sense that the more you could minimize unmet need, the better your patients are going to do. Streamline your clinic processes to reduce barriers for persons attending clinic. When they show up, be as efficient as possible, because if you turn them off or put barriers in their way, it's going to keep people, or some people, from coming back. And once they're gone, it's really hard to get them back. Improve the customer's experience. Again, there's no prospective data on that. We're working on that, but it's such an intuitive approach, it doesn't seem reasonable to not try. How could you not want to have a satisfied customer? Work with the ERs, your inpatient services, your CBOs, public health agencies, prisons, other providers in the area to identify poorly retained and build or strengthen relinkage processes. Some patients do disappear, but a lot of them access periodically other services. So try to build networks within those services. Outreach and peer navigator programs can be very effective for certain populations. I don't care how empathic I am as a physician. I don't have HIV, and I can't relate to my patients' lives. I can't relate to the stigma they have. But a person who's been through that has a power that I don't have. It's not a panacea, but it can be useful for some patients. Spread the word about the importance of retention, have staff advocate for retention, and problem solve with your patients. This is probably the most important thing. Every patient's different. The reasons why they're in care or out of care are unique to them. You've got to problem solve with your patients collaboratively, just like we do with adherence to medications. Barring that, you're unlikely to have a major effect. And retention and care tame the gorilla. So I want to acknowledge my Baylor College of Medicine and the VA, where I have a research office as well, the Harris Health System that runs Thomas Street Clinic, and my funding, as well as colleagues, especially Reve Amico and Mike Magavero, who are the very generous colleagues and always interested to talk about these issues. Thank you. Happy to take any questions. David.
So in your trial,
Yeah.
there are other ways you should be doing it.
Yeah, so David's question basically is, are these interventions that have statistical significance, are they worth it? Because is the magnitude of the benefit enough? It's a great question. I think, when I started 10 years ago in HIV care, adherence was where we are now. There were no great interventions. We had to do something. And the interventions that were statistically significant, a lot of the effects waned over time. And we had two choices. We could either wait for the silver bullet, which still hasn't arrived, or we could act and try to do something. And so most places chose to act and try to improve adherence to medications. And I think over time it has improved because we've learned bits and pieces from each of the studies. Now it's dangerous to say, well, I know in this intervention what worked was X and Y didn't really help. That is you can't disentangle the intervention effect that easily. But I think we learn basic principles from these studies that brief messages about the importance of care and about how to stay in care can have some effect. So think about what you can do in that realm. That training behavioral skills is difficult and may not be worth it, at least the way we did it. That case management and decreasing unmet needs are critical. And you've got some randomized data as well as a lot of observational data to back that up. Now, in terms of what you can do in your clinic, how to pick which you're going to target, that's a unique decision that each clinic has to make based on the resources. You know, when I started, we had one case manager for a clinic of 3,000 people. Now we've got a lot of case managers, and we can do more case management. So it all depends on what resources that you've got. Yes, in the back.
Thanks for a great talk.
Thank you.
So I'm interested in intervention.
Sure, thank you. The question was basically, what about bringing the clinic to the patient instead of trying to bring the patient to the clinic? The evidence base for that, so the PACT intervention that Heidi developed and is rolled out basically across the state of Massachusetts is, as well as other places, is about adherence to medications. Very intense, maybe cost-effective, but very, very intense. Chinazzo Cunningham in New York did a study of out-of-care homeless, people living in single residency occupancy hotels and other homeless, and did a randomized study of home visits to these people who had HIV to see if that could improve their outcomes. And in fact, it didn't work. Patients just were so unstable that they had poor losses to follow, or they had high losses to follow up. They had people who said, yes, we'll be here for this visit at this time, and then they weren't there. I don't know of any other randomized trials. We are currently a SPINS site for an intervention to bring HIV care to homeless shelters in Houston, and there are 8 other sites across the country. So trying to decentralize HIV care out of the center of excellence, like Thomas Street, and bring it to the homeless shelters. It seems like a great idea. The effort involved, though, is not going to be trivial. If you can see 4 home visits in a day, you know, that might be a lot. And that's clearly not an efficient use of healthcare resources. It may be that you've got to target that for the right patients. But I don't know how to pick those targets. And there's all kinds of, you know, legal and other regulatory issues around that, too. Sorry, yeah. Yeah, so in our CDC projects, we showed that it worked across all the age groups. The youngest are often the most difficult. That's clinical impression as well as data to show that. They often have the least advanced HIV, they feel the best, they have the most competing needs. There was a SPINS project on youth, MSM youth who are either black or Hispanic or other racial ethnic minority that did non-randomized interventions to try to improve retention and care. And what emerged from that, and actually Lisa Hightow-Weidman was one of the great sites for that project. And what emerged from that was really engaging youth in a youth-friendly clinic with appropriate marketing materials, with co-location of services is a nice way to try to engage youth. And she can speak to that, her intervention, far better than I can. I know at our site, when we were part of that, co-location of services and bringing together a whole team for that very unique patient population helped. Well, so the question is, what's the evidence for peer navigators and peer support? There's a lot of ways to answer that question. If you look at internationally, a lot of places require persons wanting to start ART in developing countries, for example. They require that the person attend visit with a peer or with some social support. The evidence for that actually working isn't great because a lot of those, it was a common sense sort of approach and not studied in randomized trials. And some people fear that it's actually a barrier. You know, if you don't want to disclose, while sure, it's better if you disclose and you have social support, if you don't choose to do that yet, it's hard to access care, hard to access therapy. So there's controversy around that approach internationally. Domestically, there's a lot of people using peers, but there aren't any randomized data to say that it works. That's why we're doing our study of a peer mentoring approach in these hospitalized patients who are out of care. We'll have results in about a year. We're almost done with enrollment. We've enrolled 420 people to date. We've got about 20 more, so we're almost there. But the data for peers is observational. And in our, we have a quasi-experiment. It's not published, but when we assigned people a peer at entry into our clinic, they had higher rates of attendance for the early appointments. But yeah, you're right, it's not evidence-based. So again, you've got to target that to people who you think might benefit from it, and you've got to find the right peers, because that's critical. You can't just sign everyone up. And whether they're supposed to be paid employees or they're going to be volunteers is an important decision. How to deal with confidentiality issues, how to deal with access to electronic medical records or other medical records is important. Barriers or boundaries for the peers is really critical. There's a whole literature and technical assistance literature about how to work peers into your clinic. HRSA and Ryan White are very interested in that topic. So there's a lot of assistance out there, but the evidence base is not tremendous yet.
So we had one question from the
I think a more integrated EMR has tremendous potential. There's no doubt about that. A virtual healthcare team can be constructed in ways that were impossible before, when you've got CBOs and in one location on one separate record and clinicians on another location on a different record. And the jail using another record. If you can integrate that into one universal electronic medical record, that is fantastic. But again, there's no data to support that. But it makes a lot of sense. And I know from our clinic, when we transitioned to an electronic medical record system-wide, it was a breath of fresh air. It stinks having to type all this stuff in. I'll be the first to admit it. And I'm not as efficient a clinician as I used to be when I could just jot a few scribbles on paper. But I can read what the consultants say now in real time. And I can find the viral loads. I don't have to, do this. And I can see what happened when the patient was in the hospital. So it is a tremendous improvement. And then if we can get to systems where we use Epic, and there's a feature in Epic called, I think it's called Universal Epic or something like that, where all the Epic systems can talk to each other across hospital systems, as long as the patient consents to that. And that would be, can you imagine if there really was a universal EMR that you could see? Back when I was a med student, I naively thought that existed. Boy, was I surprised when I found out it didn't. So thank you very much for your attention. I really appreciate the opportunity to talk to you.